Welcome back, ladies and gentlemen, to the YourGoToDoc YouTube channel. I'm Dr. Robert Feldman, neurosurgeon for over 25 years, talking about various neurosurgical issues and problems that I basically deal with patients every day. Today we're going to be talking about an unfortunately relatively common problem and a relatively painful problem called vertebral compression fractures. As the name suggests, this is a broken bone in your spine. Very painful and, again, unfortunately, relatively common. So in today's video, we're going to talk about what a vertebral compression fracture is, why it happens, or the multiple reasons on why it can happen, symptoms that it can cause, what it looks like on pictures, x-rays, CAT scans, MRIs, and then we'll talk about treatment options. We'll go over the risks and benefits to those treatment options, as well as the alternatives. So let's take a look at this problem and talk about it in more detail. As the name vertebral compression fracture suggests, the fractures occur in the vertebra, which are the bones of the spine. If you look on a model, those vertebrae are the squares. And these occur all up and down the spine, from the lowest lumbar segment to the highest segment in the top of the neck. So a vertebral compression fracture doesn't specify where in the spine that occurs. It's just saying a broken bone in the spine. Compression, as the name suggests, the most common force or load that's going to cause a fracture in the spinal column is a axial or compression force, so a force that kind of pushes the bones together like that. So vertebral compression fractures occur in the bones of the spine, and let's talk about why that happens. So the two most common causes or reasons why a bone in the spine might break is number one, osteoporosis, and number two, cancer. Osteoporosis is basically a failure of calcium to deposit properly in the spine. This occurs most commonly in elderly women or women that are past menopausal age. Because of those hormonal changes, the bones don't get calcified as much as they should. They lose their calcium and don't replace it, and as a result, it becomes brittle and weak and more susceptible to fracture. Osteoporosis can occur in men, but it is much less common, but still possible, and men can also get compression fractures from osteoporosis. Second most common cause is cancer. A couple of cancers are more prone to spread to the bones of the spine than others. Breast cancer in women and prostate cancer in men are more prone to spread to the spinal bones than other types of cancers. If cancer cells replace regular bone cells, then you've got soft cells in there instead of hard material, and that also will weaken the bone and make it more susceptible to fractures. So what kind of symptoms would one get if they had a compression fracture in the spine? Well, the number one symptom is pain. That is the typical symptom that will lead to seeing a physician about this and leading to treatment. In rare circumstances, compression fractures can be severe enough where the bone actually pushes back towards the spinal canal and the nerves and can actually injure or upset the nerves of the spine and cause a neurological problem, which could be numbness or sensory loss, as well as weakness. In those types of cases, treatment is more likely going to involve some kind of open surgery where you're actually unpinching those nerves. But in the majority of cases, compression fractures do not cause neurological deficits or problems, and typically the number one issue is pain. Why do compression fractures hurt? Well, it's a broken bone, just like a broken arm or a broken leg. They hurt. The pain from a compression fracture can be more severe in the spine than other parts of the body because, number one, it's very hard to immobilize the bones of the spine. If you break your arm or your leg, they can put it in a cast, and by keeping those bones still, it can lessen pain. It's very hard to put your spine in a cast, or at least in a cast that's effective in immobilizing the spine. One of the big reasons for that is simply being vertical, your spine is suffering the consequences of gravity and being put under load or force, which is going to aggravate or irritate the pain of a fracture. So that reason of it being very difficult to immobilize the bones in the spine actually was one of the reasons that led to one of the most common and popular treatments for compression fracture today, which is something called kyphoplasty, which we'll talk about in a little bit. So let's talk a little bit about what would actually lead to a compression fracture in the typical patient that would get a fracture like this, and then what would lead someone like that to eventually end up in my office asking for treatment for this. So if we back up to how this would happen, typically, as we said, the patient will be a postmenopausal female with osteoporosis, likely undiagnosed or improperly treated. So they've got weak bones, not just in their spine, but all over their body. If the osteoporosis is severe, it could be some activity as simple as stepping off the curb too hard, or lifting something heavy in the house. If the osteoporosis is not that severe and maybe moderate or mild, it may take a stronger force, like a fall. Typically that fall would be a fall backwards, landing on the buttocks, where you would have, again, a compression or axial force, where you basically slam down on your butt cheeks on the concrete, and boom, all that force is transmitted upward through the spine, and because the bones are weak, you get a fracture. Typically, that'll be sudden onset of severe back pain in the area of the fracture. You may then later get severe muscle spasm because your brain is attempting to keep that area still without your permission by tightening up all those muscles around the area of the fracture. This could be severe enough that you're literally bedbound for 2 to 5 days because literally it hurts too much to move. Typically, patients will self-medicate. Motrin, ibuprofen, Advil, Aleve, Tylenol. If they have stronger medications in their house, they'll take those. That typically won't work too well because, again, if you're lying still, it tends not to hurt as much and the medication may help. But as soon as you move and that bone is under pressure or force, the pain is typically severe, that of a broken bone kind of pain. This will then lead to an appointment or a telephone call to the patient's primary care physician or a visit to an urgent care center or an emergency room. And based on the history of how this happened, usually a fall, combined with some x-rays that will show a fracture, the patient may be put in a brace and given stronger medication and told, wait 2 to 4 weeks and to see if this will heal on its own, and if it doesn't, call us back or come back. If the pain is so severe that the patient is literally incapacitated and cannot perform their activities of daily living, they may skip those 4 weeks or 2 weeks and be sent to someone like me right away. But if after 2 to 4 weeks the symptoms just aren't improving or are not improving enough, they would then be referred to someone like me for options for treatment. The patient's then going to show up in my office, typically with a walker or a cane. Very difficult for them to sit down or get up. On physical exam, typically everything works. They're going to be neurologically intact, but they're just describing serious pain. They can often localize that pain to a relatively small area in the spine. There will likely be a lot of muscle spasm that I can feel as the doctor. If I press on those muscles, they're hard as a rock around the fracture area. And then palpation of the spinous processes in the back of the spine, which are those little pointy bones in the back of the spine. If you push on that at the level of the fracture or wiggle it a little bit, the patient will say, that's where it hurts. Usually the patients are going to show up in my office with some kind of picture. So if that spot matches up with the spot on the picture where the fracture is, I'll have a pretty confident suspicion or idea that that's where the pain is coming from. Combine that with the story, I fell, I stepped off the curb, sudden onset of pain in that area that's not getting better. I'll be pretty confident that that's the source of the pain, which in turn means that treating that source could potentially alleviate their pain. The image we're looking at here is an x-ray of the spine, and this is a side view of the spine. So the squares are the bones, and you can see very plainly that this bone in the middle is not a nice square shape like the one above it and the one below it. You can see the top part of the bone is crushed. This is a common spot for the fractures to occur. And you can see the height of the back part of the spine, or back part of the bone, is relatively well maintained, but the front part is collapsed. And that's also a common sight to see for vertebral compression fractures. These pictures are CAT scans of the spine. The one on the left is similar to the X-ray that you just saw. The blocks or squares are the bones seen from the side. And here you can see this bone is a different shape. It's not really a very good square shape compared to the bone above and below it. You can see the front top part of this bone is kind of crushed into itself. You can almost make out a fracture line here. You can see the overhang of this bone, and this is a compression fracture of the upper part of the bone. Pretty classic looking picture for a compression fracture for a CAT scan. If you turn this picture looking from side to side and instead look kind of down the barrel of the gun, so to speak, and you're looking down the tube of the spine, this is the picture on the right. This Y-shaped bone back here, this bottom part of the Y, is the pointy things we feel running down our spine. So this is the back of the spine. This center area here with a grayish looking circle in it is where the spinal canal and nerves live. And then this is an end-on view of the vertebral body. And this is what this bone on the left would look like if you looked at it from the top down. And you can see the fracture lines in the front edge of this bone. And these fracture lines correspond to this fracture line. So this picture on the right is as if you were taking a slice through this picture on the left, right through here. And this is what the bone looks like down the tube kind of view. Now, if the fracture is not in the front here, and it's in the entire vertebral body, you could get fractures along the back wall here. And that could make the nerves that live in here at risk. So sometimes a patient who has a lot of fracture lines in the back here are not really good candidates for the treatment for this, because the treatment involves putting bone cement in here. And if that bone cement leaks out through cracks in the back wall of the vertebral body, you can get bone cement in the spinal canal, which is not a good thing. So if you saw fracture lines in the back here, the patient would probably not be a very good candidate for the surgical option for vertebral compression fractures. Now, I actually have done this procedure in people who've had fracture lines back here. One of the keys to getting away with that is you want to make sure that the cement stays towards the front. You want to make sure the cement is thick enough that it's not going to be too runny and run back here. But we'll talk about those type of issues when we get to the treatment of these fractures. Next, we're going to look at an MRI of the lumbar spine. The picture on the left is called a T1 image. Anything that has water will be dark or black. Anything that has fat type tissue will be white. On the right is a T2 MRI, where anything that has water in it will be white. And here you can see all the bones in the spine on the left look the same as far as coloring, even though they're kind of heterogeneous and different textures. This particular bone here is almost all dark compared to the other ones. And this is evidence of a fracture on a T1 MRI image. And the same on the right, high signal on the T2, whereas all the other bones look pretty much the same. This is a classic example of a compression fracture on a T2 MRI. And you can see usually the back wall of the bone is not really compromised, and it's just kind of wedged or collapsed more towards the front. And that is the typical compression fracture, particularly with osteoporosis, which can be very painful. Okay, now let's look at some variations on the typical compression fracture configuration. This is an example showing that sometimes compression fractures don't even look compressed. On an X-ray or a CAT scan, the bone may look still like a pretty good square shape, but the patient had a fall, the patient has osteoporosis, the patient has pain in a localized area, all sort of data points to the idea that they have a compression fracture somewhere, but when you get an x-ray, the bones look regular shape. Well, this just goes to show that even though the bone may not have changed shape, it still may have a fracture. So, for example, if you look on the far right, this is a CAT scan, and I apologize for the contrast being a little dark, but this bone right here, relatively speaking, is still a pretty good square shape. It may not be very suggestive of a fracture. But if you look at an MRI, you can see on the T2 signal MRI and the T1 signal MRI, there's an obvious abnormality in the color of the bone here. And this is typical findings of a compression fracture seen on MRI that has relatively good height. These patients are going to have just as much pain as a fracture that does not have good height, and also could similarly benefit from the treatment for this kind of fracture. So that's one of the reasons why all patients with compression fractures, I like to get MRIs. And one of the reasons for that is, number one, if I'm having trouble seeing it on an x-ray or a CAT scan, and number two, it's quite possible that they might have a very significant fracture at, for example, L3, where the bone is crushed and has abnormal shape, but at L2 or L4, the bone looks normal on an x-ray, but on an MRI it lights up with a bright white signal on T2 or a dark signal on T1, and that might suggest that they really have two compression fractures. And ideally, if you're going to treat the one that looks bad on an x-ray while they're asleep or while they're under anesthesia, you want to treat the other one also, even though it doesn't look broken on an x-ray. And that's why MRI can be very helpful in identifying fractures that are there that you don't necessarily see on x-rays or CAT scans. Now let's look at another variation of compression fractures. This is called vertebra plana, which basically means such a severe compression fracture that the bone is almost in a single plane. It's crushed so much that it's really just a thin block of bone or thin wedge of bone. This on the left is a CAT scan. This on the right is an x-ray. And you can see these fractures in between the disc here and a disc here. This fracture of the bone and this fracture of the bone is extremely small and thin and narrow, and probably would make these patients not a candidate for kyphoplasty, which is what we're going to talk about when we talk about the treatment for these fractures. Unfortunately, these patients are going to be left with conservative options for treating this fracture, which is basically bracing, time, and medication. And we'll also go into that in a little bit. But this is an example of vertebral plana. Again, typically a contraindication to treatment with surgery. Another thing to keep in mind is that compression fractures sometimes heal without ever being known. A patient gets a compression fracture, they have back pain, but either it's not bad enough to interfere with their activities, or they have such a good pain tolerance or high pain tolerance that they can put up with it while it heals. And eventually these fractures can heal just like, another broken bone. And if we take a look at this picture here, we can see on the left an x-ray showing a pretty classic compression fracture, wedge-shaped bone. And the patient may have no symptoms or symptoms coming from somewhere else that gives them back pain. And if you then get the MRI, as I like to do, you'll see that that same bone on an MRI does not show an increased signal or white color like you'd expect on this T2 MRI if it were a new fracture or a healing fracture. So the fact that the color of the bone here looks like all the other bones suggests that this fracture has healed and would no longer therefore be painful to the patient, which means that treating it would not help the patient, and if they have back pain in that area, it must be coming from somewhere else. So this just goes to show that just because you've got a fracture on an x-ray, let's say, or even a CAT scan, it could be an old fracture, so it's a good idea to check that out with an MRI. The other reason that could be helpful or important to get an MRI is because they could have a fracture down here that's new and a fracture up here that's old, and we'll take a look at that on the next picture. If we take a look at this picture, we see this is an MRI T2 signal MRI. This patient actually has two compression fractures. This bone does not look like a normal square shape. That bone does not look like a normal square shape. But you can tell immediately that this bone above here, even though it looks fractured, it's a healed fracture or a chronic fracture. The bone signal intensity is the same as normal bone, which suggests that this is no longer an active or acute fracture. It is no longer symptomatic, and therefore treating this, even though it may not look normal on an X-ray or a CAT scan, would be of no benefit to the patient. Whereas this fracture is relatively fresh and new, is likely the cause of their symptoms, and would benefit from treating. Again, this just goes to emphasize that getting an MRI is important. If you were going to treat this patient just based on an X-ray or a CAT scan, you might end up doubling their time in the procedure room because you do 2 levels when you only really needed to do 1 level. So this is an example to emphasize the fact that even though a fracture shows up on an X-ray or a CAT scan, it may not necessarily be new. And if the patient is having symptoms from that area, you could very well be dealing with an adjacent level fracture as the cause of their pain as opposed to the other level. Last but not least, this is a variation of a compression fracture, which is a pretty typical finding when you see a tumor or cancer as a reason for the fracture. In this case, the bone is pretty evenly colored or discolored compared to the other bones in the spine. So you can see all the other bones not only are normal shape, relatively normal shape, but they're all kind of a grayish, whitish gray color, whereas this bone is dark and dark pretty much throughout the entire bone. Often with compression fractures, you'll see spotty areas of color change where the bone has been broken and other areas of the bone that are normal color that have not been broken. But in this case, the bone is pretty homogeneously or evenly colored. This is highly suggestive that there might be a tumor in this bone causing it to be weak and change shape. This could be further evaluated with an MRI with and without contrast. On the T1 image like this, without contrast, it'll be dark, and then with contrast, this will light up nice and bright. Another option would be a biopsy, which would probably be done whether the patient undergoes a procedure to treat this or not. You would send the patient to the radiologist if you're not going to do a surgery on this, and they would just use a CAT scan to guide a needle into this bone and take a sample, and then send that to the pathology lab to try and find out if there are any kind of tumor cells in here. But this is an MRI of the spine, and this is a pretty typical example of what a compression fracture looks like when the cause of that fracture is a tumor. One final thing to mention is that some people can't get an MRI. They can't get it because they have a pacemaker, or they have metal in their body, or there's a shrapnel somewhere. And an MRI is not possible to get, and I've already mentioned why I think MRI is important. So there is one other test that you can get that will help you determine that a compression fracture is new or would benefit from kyphoplasty, and that is something called a bone scan. A bone scan is a nuclear medicine scan, which basically means that you use a nuclear radioisotope that's injected into the bloodstream, and then that will get picked up in an active fracture, and it'll light up on a scan like this. And in this case, you can actually see where the vertebral body has these dark spots, which are basically radioactive material that's lighting up and giving off energy that a photosensitive plate or a photosensitive machine can translate into an image that shows you this is a new fracture. And again, this is helpful in somebody who can't get an MRI and you're not sure if the fracture is new or old. This will help you determine whether it is new and whether it would benefit from a kyphoplasty. And this is an example of a bone scan lighting up in a spot with an acute or active fracture. So the patient or you're sitting in front of me in my office. Most likely at this point, you've had some kind of imaging. You've probably waited 2 to 4 weeks of trying non-surgical or conservative options like medications, wearing a brace, decreasing activity. So by the time you get to see me, it's probably time to talk about treatment options other than what you've tried already. So one of the things to keep in mind that I will tell patients is that in the old days, the way they treated these fractures was with a brace, time, and medications like narcotics. Now, what they found was that that treatment was typically inadequate, and it led to, down the road, multiple problems and complications that caused significant problems for the patient, including killing them. And what would happen is these patients, which were typically elderly women with osteoporosis, were in so much pain that they couldn't really move around very much. And as a result, they would lie in bed all day. Well, that would lead to downstream problems like bed sores that would get infected, urinary tract infections, malnutrition, pneumonias because they're not taking deep breaths because it would hurt to take a deep breath. So a lot of these patients that were treated with conservative non-surgical options would kind of waste away in bed for weeks and weeks developing all these complications or secondary problems because they were lying in bed all day. A lot of times the pain medication that these patients would be given would lead to suppression of appetite, or the pain itself would suppress appetite. And a lot of these patients were not or would not be eating well already as it is. So again, as contributing to malnutrition, and then all the complications and issues of being still in bed all the time. So when they looked at the data and saw how many patients were being negatively affected indirectly because of all these other problems as a result of these fractures, there was a lot of incentive to come up with a solution. And the solution that they came up with first was something called vertebroplasty. Vertebroplasty basically meant squirting bone cement into the broken bone. And basically that bone cement would go in like toothpaste and then get rock hard over a couple of minutes and would then cure inside the bone and make it hard again. There was some argument over why that actually made the patient feel better, but they would actually feel better immediately after the procedure. This procedure could be done with the patient awake and a little bit of numbing medicine, or totally asleep. But either way, the patient would get the cement put in the fracture. They'd wake up and they'd be like, oh my God, this doesn't hurt anymore. I feel great. So the theory behind why the bone cement makes the patient feel better, theory number one, by making the vertebral body hard again by putting cement inside of it, it puts pressure on the periosteum, which is the membrane that lines the bone, the outside of the bone. And that's where most of the nerves are in the bone, at least the nerves that feel pain. So making that bone rigid and hard again stretches the periosteum, or at least keeps the periosteum from being able to move a lot, and therefore calms all those pain nerves down. The second theory as to why vertebroplasty would help with the pain of a broken bone in the spine is that when the bone cement cures from being soft like toothpaste to hard like bone, is an exothermic reaction, which means it gives off heat. So one of the theory is that the heat that the bone cement gives off inside the bone actually burns the little nerves that cause pain and makes the patient feel better. So those were the kind of two theories about vertebroplasty. Now, how would the vertebroplasty work? The patient would be given some happy medicine, some forgetting medicine, or be totally put to sleep under anesthesia. They would be carefully rolled over on their belly on a special table. X-rays would be brought, or X-ray machines would be brought in so that you could see what you were doing while you were doing it as the surgeon. You'd make two small incisions, maybe 1/4 of an inch long, right over the bone that was broken on the left and the right, and you would use X-rays to guide the needle through the skin, through the muscle, into the bone that's broken. And you would do this on the outsides of the spinal canal, and I'll show you what this looks like on some pictures in a minute. And put that needle inside the bone, and then literally, after removing the stylet or center wire from the inside of the needle, you would push cement through that needle into the vertebral body or bone that was broken. And that needle, because it's kind of the consistency of toothpaste, would kind of work its way into the nooks and crannies of the vertebral body or the bone, and then eventually harden. Great procedure. A lot of people were helped by it, but there were some issues with potential complications, and we'll talk about in a separate section of the video the risks of this surgery. But one of the risks was that bone cement could push out of the back of the bone and push into the spinal canal and bother the nerves. So that led to another development in this treatment, where what could they do to lower the risk of that bone cement pushing back out? Well, one of the ways to lower that risk is make it so that the surgeon doesn't have to push so hard to get that cement into the vertebral body or broken bone. So the next development and treatment was something called kyphoplasty. So with kyphoplasty, it's kind of the same concept as vertebroplasty, but it's got a little tweak to that procedure that lowers the risk of the cement backing out. So what is kyphoplasty? Well, kyphoplasty is the same procedure as vertebroplasty, except before putting in the needle to allow the cement to go in, you put in a balloon into the bone. And this balloon is at the end of a wire, and you pass it through the needle into the bone, and then you literally blow up the balloon. And the balloon is blown up with some material that you can see on an x-ray, so you can actually watch it expand inside the bone. And you can blow it up to the point based on how it looks on the x-ray, or you can blow it up to the point of how much pressure is in that balloon. There's a little gauge on the balloon blowing up equipment that tells you how much pressure the balloon's under. And the goal is to create as big a cavity inside the bone with that balloon without bursting it or breaking the bone around it. And that balloon is made of a material that's pretty dense and strong so that it can crush the cancellous bone inside the vertebral body and create that cavity. Now you've got an empty space inside the bone, which allows you to push the bone cement in with a lot less pressure and fill that space full of cement, and then it kind of also works its way around that cavity. So that procedure called kyphoplasty lowered the amount of pressure you have to use to get the cement in and significantly lowered the risk of that cement breaking out at the back of the bone into the nerves. Let's take a look at what this looks like on a model. Okay, so here is an example of a kyphoplasty setup. So if we look like the patient is lying on their belly and we're looking straight down at their spine, you can see this tube is going into the bone right here, and then attached at the end of that tube is the balloon. This is blown up right now, but when it goes in, it's collapsed. And you can see when you blow up that balloon, it creates a space inside the bone. Here's one on the other side. You don't see the needle there because I think that broke off. But anyway, after the balloon is blown up, you deflate it, take this out, and now there's, and you take it out of a metal tube that's already in there, so the metal tube is still there. Take out the balloon, and through the same metal tube that the balloon went in, you put in the needles that have the bone cement in it, and start pushing the bone cement into these cavities. And what I'll do is I'll show you a picture of what it looks like on an x-ray after the bone is filled with the cement. And we'll look at a picture that shows the big ball of cement where the balloon was, and then little tendrils of cement snaking into the nooks and crannies around it. Keep in mind also that another way to kind of adjust how that cement moves inside the bone is how thick you allow it to be before you put it in. You don't want it too thin, because if it's too thin, you can run into some complications that we'll talk about, where the bone cement can leak into spots you don't want them to leak into. If it's too thick, then you have to push too hard to get it where you want it to be. So as I said, my preference is to let the bone cement kind of get to the consistency of toothpaste before you start pushing it into the bone. The other thing you have to remember as the surgeon is that the bone cement will cure faster when the temperature is warmer. So body temperature, 98.6 degrees Fahrenheit. As the bone cement gets into the bone, it's going to heat up and cure faster. So for me, the starting point is about toothpaste consistency. By the time you get it into by the time you start getting into the bone, it's going to get even thicker because of the heat of the body. So when you start pushing that cement in, it's going to be just perfect for getting it where you want to and not where you don't want it to be. Let's take a look at an animation of how kyphoplasty is actually done. This video is compliments of Medtronic Spinal for their kyphoplasty device system. This is actually the system that I would typically use to treat compression fractures with kyphoplasty. And when looking at this animation, you can see the fracture of the bone with the crushed vertebral body, and the two needles going through the pedicles, which are the columns of bone that connect the back of the spine to the front of the spine. This is the pedicle right here, this section of bone, and these two needles are coming in through the back of the spine, through the pedicle, into the vertebral body. And you can see the stylet is removed and a drill is passed through the tubes, and a hole is drilled into the bone. This creates a space for the collapsed balloon to then be inserted into the bone. The balloon is then blown up. This not only creates a cavity that you can eventually put the cement in, but it also can sometimes restore the height of the bone. The restoration of the height is not necessary for pain relief, but it does improve the biomechanical situation of the spine by creating a more cube-like bone structure as opposed to a collapsed bone structure. Some believe that this can actually lessen the need for muscle spasm in the back of the spine because the biomechanics of the spine are restored by increasing the height of that broken bone. Again, the balloon sometimes can increase the height, sometimes it doesn't, but the pain relief is still there. So the balloon is inflated, height in this picture is restored, the balloon is then deflated and removed, leaving a cavity in the bone. Then bone cement is then pushed into that cavity like toothpaste, as you can see here in the in the animation. And that bone cement eventually hardens over 5 minutes or so and restores the integrity of that bone and makes the pain go away. Those are the incision sites that it takes for the needles to go in, so you can see it's a relatively minimally invasive procedure. And that's pretty much an animation of what's done in a kyphoplasty. So you've put the needles in both sides of the vertebral body where the fractures are. You've blown up the balloons to create cavities. You've put in the bone cement on both sides to fill that bone with bone cement. And then you take all the needles out, wash out the incisions, put a couple staples or stitches in there or glue to close up the incisions. Remember, they're very small, only 1/4 inch long. Take some final x-rays to make sure that the cement that you put in is where you want it to be. And keep in mind, we usually mix the cement with some special stuff that makes it so you can see it on the x-ray. And if everything looks good, sew the patient up, roll them over back on their back, wake them up, bring them into the recovery room. Usually I'll go do some paperwork, let them wake up a little bit longer, and go back in to check on them, and I'll ask them, how do you feel? Typically they will tell me they don't feel the surgery pain at all, and usually that's because I'll numb up the skin and the muscles around the needle that went in, and they tell me that their back pain's gone. That's how fast they feel better after you've restored the hardness of that bone. Also, just to remind you, most physicians, while they're in there with their instruments, will take a little sample of bone from inside the fracture and send it to the pathologist, because we want to make sure, let's say the patient has osteoporosis, there's still a possibility that it could be cancer that's causing this bone to be weak. So we want to make sure that what we see inside there is just normal reactive bone tissue and not some kind of cancer. The patient will usually go from the recovery room either up to a regular room, and I'll either keep them overnight, or they'll go back to the holding area, and once they can eat something, drink something, and walk and go to the bathroom, they can go home. I'll typically tell them to stay in the house for a day or two, and that doesn't mean lie in bed all day, but just stay home. They're allowed up and down steps, sit on the porch, watch TV, read a book, take a nap, stare out the window, watch the grass grow. One of the reasons, even though it's such a small procedure, I'll let them or I'll want them to stay in the home for a day or two, is that I typically do these procedures with the patient under general anesthesia, so they're asleep for the whole thing. It's a little less traumatic for them. And because these patients are typically elderly and they've had general anesthesia, I want all that anesthesia to really wash out of their system before I start letting them do more things, so that they're more steady on their feet and they don't feel kind of woozy or off balance from just the effects of the anesthesia. After 1 or 2 days of being stuck in the house, I pretty much let them do whatever they want. They can drive, they can exercise, they can go back to their usual routine. They'll be back in my office for a week for my nurse to look at their incisions, make sure the incisions look good, take out any staples if they've got staples, and then I'll see them a week later, which is 2 weeks after the surgery, for their final checkup to make sure that their incisions look good and that they feel good. If everything looks good at 2 weeks, they're off the hook. They don't have to come back. If we did find some newly diagnosed osteoporosis, I will refer them back to their primary care physician for treatment for that at the primary care doctor's discretion, whatever their favorite medication to try first for osteoporosis is. And if something comes back with cancer, I'll of course refer them to an oncologist for further evaluation and treatment for that. So for vertebral compression fractures, you've got non-surgical options, which include bracing, time, anti-inflammatories, muscle relaxers, and pain medication. That's pretty much the 5 things that you can do for this kind of problem. If that's not effective, or the patient is in so much pain they can't function, you can then consider surgical options, which nowadays include something called kyphoplasty, and that's where you basically put a balloon into the broken bone, create a space, deflate the balloon, take it out, and then put in bone cement. The bone cement, again, goes in like toothpaste and then gets rock hard in about 5 minutes. Very effective treatment, very low risk, and typically can be a dramatic difference in symptoms with almost complete pain relief, typically when the patient wakes up in the recovery room. That kyphoplasty procedure can be done either with a surgeon like myself or with the interventional radiologist at a hospital. If it's done by the radiologist, the patient will typically not stay overnight in the hospital and will go home the same day. Also, when done by the interventional radiologist, patients are typically not put to sleep with general anesthesia. They're awake for the procedure, which is certainly an acceptable option, and usually they'll be given some happy medicine or some forgetting medicine to kind of get them through the physical and psychological trauma of the procedure. The last thing to really talk about, kind of sum up, are the risks of that procedure. The 3 risks for kyphoplasty that are the same for any procedure, it doesn't matter what kind it is, are risks of infection, bleeding, problems with anesthesia. Risks of infection are pretty low. You're often given antibiotics before the procedure and sometimes after, and the procedure is done in a sterile environment. Risks of bleeding are very low because of where this procedure is. There aren't any big blood vessels or things to worry about with the instruments that are using for this procedure. I guess theoretically, if the needles that you're using are passed too far through the bone and into the thoracic or abdominal cavity, you could actually hit a big blood vessel, but I've never heard or seen or read of that happening, but I guess theoretically it is. But risk of bleeding, extremely small. Risk of anesthesia are basically things like pneumonias, urinary tract infections, injury to the mouth or throat from the breathing tube if you're going to be put to sleep, blood clots in the legs that can travel to the lungs. Because these procedures are relatively short procedures, these are all very little risk, very small risk. But because many of these patients are elderly and have a lot of medical problems, risk of anesthesia could be significant. And there are cases where I've had a patient come and see me with a fracture that they would be a good candidate for kyphoplasty, except for the fact that they're very elderly with a lot of medical problems. In that case, if I feel that going under general anesthesia would be too risky for their heart or their lungs or their kidneys and things like that, I will refer the patient to the radiologist for this procedure where it's done with them awake to lower that risk of being put to sleep with general anesthesia. So those are the 3 risks for any surgery: infection, bleeding, problems with anesthesia. Now, there are a couple of risks that are special to this surgery because of where it is and what we're actually doing in kyphoplasty. And one of them I've touched on before is the bone cement or pieces of bone can break out backwards or towards the back of the spine into the spinal canal where the nerves are and injure or upset the nerves. This is a relatively low risk. With the advent of kyphoplasty, where the balloon creates a cavity, that risk has become lower. But if the surgeon isn't careful and allows the bone cement to be too hard before they put it in, or if the surgeon pushes too hard, or if the introducer needle is angled inappropriately so that it's too far towards the back of the bone, there is a theoretical risk that the cement or the back wall of the vertebral body can push back into the spinal canal. There are many case reports in the literature about this happening. I've seen this happen to other patients. Knock on wood, it's never happened to one of my patients, but it's in the books, so your surgeon and I have to kind of tell you about that. The second special risk is something called bone cement thromboembolism, and that can occur when the cement can actually leak into some of the draining veins of the vertebral body or the bone, and can travel outside of the bone, and if bad enough, it can actually travel all the way into the lungs, and you can get little clogs of bone cement in the veins of your lungs. The biggest reason this happens is because the bone cement is put in when it's too thin or liquid. Again, you have to wait for that bone to get like toothpaste, so it's thick enough that it's not going to get into those veins and travel. Now granted, if it gets to those veins, because of the heat of the body, the cement can cure faster, and a lot of times those little veins full of cement you'll just see right outside the vertebral body. They never make it to the lungs. If that's the case, it really isn't a big deal. They just kind of sit there as clogged veins, which don't really affect you. Again, knock on wood, I've never seen that in any of my patients, but that risk is in the books, so you should be told about it, and your surgeon should be talking to you about those risks. And those are the main special risks to this particular surgery. Both very avoidable and both very rare, but again, you should be told about it. So in summary, vertebral compression fractures are fractures of the bones in the spine, more common in patients with osteoporosis, which are typically postmenopausal women. Treatment options for this are typically in patients whose pain is so severe that they can't function, or whose pain has not lowered to an acceptable level with non-surgical options such as bracing, decreased activity, and medications. If that's the case, treatment with kyphoplasty is typically the preferred avenue of treatment. This involves putting bone cement into the broken bone to making it hard again. Typically, the pain will go away very quickly with this kind of surgery. The surgery is relatively low risk with a quick recovery. So that's pretty much what's going on with vertebral compression fractures. This is kind of the short and sweet talk, but this is basically what I'm going to tell my patients when they see me in the office for this problem. I hope you enjoyed the video. I hope it was worthwhile. I hope it answered a lot of your questions while you're waiting to see your neurosurgeon or your spine surgeon about this. Please subscribe and like to the YourGoToDoc video channel on YouTube. I really appreciate you listening. And don't forget, stay healthy.